will discuss another salivary gland tuber, and we will take start with the revision of our previous lectures, and we will discuss few scenarios at the end of the lecture. We will discuss important MCQ questions. Today's main topic is Adenoid Cystic Carcinoma. Adenoid Cystic Carcinoma, the first scenario, this is a 45-year-old lady presented with the mass from the last 8 years and no significant other history. And if we see this pictures, polymorphous pictures, myxoid, myxochondrite stroma, different tubules, cysts filled with secretions, certain areas of keratin material, schemate, differentiation, metaplasia. This is the high power view tubules. This is the keratin. This is the secretions filled with eosinophilic secretions. So what is this? Is this pleomorphic edema? Is this myoepithelial carcinoma? Is this adenoid cystic carcinoma? Is this myoepithelioma? When we examine the histology and the immunohistochemistry and the cytogenetics, the diagnosis is pleomorphic adenoma. Another case, 60-year-old, 5-year presentations. This is, he is the smoker, well circumscribed cross picture, cysts filled with chocolate materials. And if we examine the histology, eosinophilic tall columnar epithelium, 2 layers, and stroma is lymphoid cells, and the diagnosis is Warthin tumor. This is the reference of this. Case number 3, 80 years old male. He was also smoker. Very interesting case. And on right side, there is swelling. And this is, if we see the low power view, similarly looking cystic tumor and epithelial linings, germinal centers, lymphoid materials. Here we 2 types of the cells, but if we go on the high power view, the cells are islands of cells with atypical morphology, mitosis you can see, and here you can see prominent nucleoli. So if we see in detail the histology, no doubt the picture is similar to that of the Warthin, but there are certain other tumor cells which are prominent nuclei, abundant cytoplasm, prominent nucleoli, oncocytic appearance, mitosis are, you can see. So the picture is carcinoma ex Warthin's tumor, but the non-invasive tumor. This another picture. This you can see almost 2 to 3 types of the cells. Some are schemate, glandular, and some are clear cells. Similar pictures. This is the musicarmine strain. If we see the histology is similar to that of the, and same the immunomarker P60. This is the mucoepidermoid carcinoma, but oncocytic variant. Today's topic, case related to the today's topic, a 50-year-old female presented a hepatic mass. On the history, the patient revealed long-standing history of swelling on the subliminal area. If there is no history, then you can confuse with the cholangiocarcinoma, or you can confuse with the hepatocellular carcinoma. This is on the left side, there is a liver. On the right side, there is a solid area with the cysts and basaloid cell on these sides. And this is the pictures, histological pictures reveal the adenoid cystic carcinoma. What is adenoid cystic carcinoma? We will discuss today in detail, but you have to exclude other possibilities when it is in the liver. In the livers, all the markers related to the neuroendocrine were negative. All the markers related to the hepatocellular carcinoma or cholangiocarcinoma were negative, but on the fish presents the translocation of the 6-9 that is called MYB. This is favor the adenoid cystic carcinoma, metastatic to the liver. What is adenoid cystic carcinoma? At the definition, adenoid cystic carcinoma, one of the more commonest, but the best recognized salivary gland malignancy can occur in minor salivary glands with prominent perineural vein and almost basaloid tumor consisting of epithelium and the myoepithelium of the cells in different patterns. Most important patterns are Cribriform pattern, tubular pattern, and the solid pattern. For the medical students, three important files. One is the basaloid cells. Basaloid cells are arranged in the three important patterns. Can be mixed pattern, but you will diagnose which the morphology will predominant. One is the classical pattern that is called Cribriform pattern, the second is the tubular pattern, and the third is the solid pattern. Her clinical feature, 5th to 6th decades, more in the females, and you can see in the minor salivary glands, 50 to 60% in the palate, then the tongue, then the buccal mucosa. Slow growing tumor. Pain is sometimes common, but the dull aches when it is a low grade, but when it is a solid, the signs, symptoms, clinical presentation worse. The prognosis of this adenoid cystic carcinoma depends on the morphology, but also depends on the grading. The solid variant results in the poor prognosis with more aggressiveness of this tumor. If it is present in the parotid, you can see the facial nerve palsy, but if it is present in the minor gland, salivary gland, could be smooth and could be ulcerated. The tumor arising in the palate or maxillary sinus may show radiomorphic evidence of bone restructures. This is the tumor that arising from the soft palate, hard palate. This is looking smooth, but with ulcerations. Adenoid cystic carcinoma. This is another gross morphology of the adenoid cystic carcinoma, where no doubt the picture is well delineated, but you can see the hemorrhagic area, you can see cyst formations, you can see the invasion of the tumor to the surrounding tissue. Area of hemorrhage are seen. What is the histology? As we discussed, this is the mixture of two cells. This is called the a myoepithelial cell and the ductal cell. The ductal cells looks more bluish color, or that is why we name it the basaloid cells, making three important patterns that we discussed previously: Cribriform, tubular, and the solid pictures. Maybe the combined pictures sometime classified. The prognosis of the patient depends upon the pattern which is predominant. We will discuss this this is the classical pattern of the Cribriform pattern. They are interlacking tubules. They just like smaller cysts, this Swiss cheese appearance or the honeycombing appearance. This is tubular pattern is also seen there, long tubular intercommunicating with each other, but make luminous stains, the mucinous cribriform pattern maybe make some time. This is the classical pattern of the solid variant. You cannot differentiate. You cannot see any of the tubule, almost solid growth, arranged in nest sheets varying size and shape of the cells. But the most the cells are basaloid cells, more pleomorphism is seen. This is different classical pictures. You can see this is the perineural invasions. Adenoid Cystic Carcinoma. The tumor cells are surrounded by the hyalinized material. If you put the fine needle expression and stain with the gimza, you will see the metachromatic material. This you see along with the perineural. Even the classical finding, the diagnosis, take the history, take the FNSC, do the biopsy, do the immunomarker and the cytogenetics. Fine needle aspiration is the classical picture, and the students are expected to the diagnose when it is in the examinations. The metachromatic material surrounded by the basaloid cell is the classical findings in the adenoid cystic carcinoma. Sometimes you can see various pictures, various size of the cells, but the cells are, these cells are equal, the more larger than the cells are the cytoplasm, and scanty nucleus, scanty cytoplasm. This is the metachromatic material. So this is the quick stain, you can see in your lab, the Gimza stain, the metachromatic matrix with the hyalinization. This is PAP stain, light blue stain, matrix frules. Same you can see metachromasia in the different stain. This was again the PAP stain, similar pictures of the spherules, spheres, and the basaloid cell. Immunohistochemistry is very important to understand for the diagnosis. Different keratins, especially the 7 cytokeratin positive, CEA and EMA is positive. Myoepithelial cells markers are positive, especially P63 we do. SOX is important to differentiate this tumor from the other tumor. When the variant is solid, it creates the confusion. So CD117 and KIT is also positive. MYB is important cytogenetic translocation of the 6-9. This also relates to the prognosis of the patient and also relates with the response to the treatment of different differential diagnosis, especially when solid and when tubular picture. One important thing is the epithelial, myoepithelial carcinoma. The important features are there. No cribriform pattern is there, and the MYB fusion is lacking, while in epithelial, myoepithelial carcinoma, HRAS mutation you can see. So in this way, we'll advise the students to concentrate on the histology, and you can advise the immunomarkers. Another differential diagnosis, the basal cell adenoma, same morphology is important, and beta-catenin and MYB will differentiate the two tumors. The third important differential diagnosis is the polymorph adenocarcinoma. Clinician must know the history of the slow growing of the polymorphous, and the histopathologist should know the histology of the two tumors. But when you feel difficulty, advise the cytokeratin, advise the immunomarkers. P40 is negative in polymorphous adenocarcinoma, while positive both P63 and 40 in this one. Another differential diagnosis is human papilloma related multi-phenotypic sinonasal carcinoma. Again, the morphology and the tumor markers will differentiate through tumor. Squamous cell carcinoma, you can take the help of immunomarkers. Cytogenetic MYB and SOX is very important to differentiate these two tumors. Treatment, surgical excision and chemotherapy, radiations can, but the prognosis is poor, especially when it is solid. And MCQ questions. This is a tumor in the submandibular glands. Biopsy was taken of a middle-aged woman, shows the following statement. It has an excellent prognosis with 5% risk of recurrence. It is characterized by point mutation involving MYB. Solid pattern is associated with adverse clinical outcome. Basically, this is the mixed variant of adenoid cystic carcinoma. And in this scenario, MCQ questions, the C is the answer because the solid pattern is associated with the adverse clinical outcome. A is, we have already discussed, not excellent prognosis. B, it is translocation, may not the point mutations. And in this way, another scenario of the MC question is submandibular biopsy was taken from a mass of a middle-aged woman and had H&E stained adenoid cystic carcinoma. Which of the following statement is true regarding the cytogenetics? Very, very important MCQ questions. We have discussed A, it has an excellent prognosis. Again, no. B, MYB, oncogene, translocation of 1119, translocation of 1215, translocation of 1222. This is again the same patients, but the reply is B. Another MC questions in the hard palate biopsy was taken. The cytological diagnosis is most likely to correspond to this cytological appearance of this ethnic carcinoma, adenoid cystic carcinoma, mucoepidermoid carcinoma, basal cell. This aspirate was taken you can see the metachromatic area surrounded by the basaloid cells, and these basaloid cells are comprised of epithelial and myoepithelial cells. So the picture, the diagnosis is adenoid cystic carcinoma. We discussed this picture. The perinuclear invasion is seen, acinix cell carcinoma, adenoid cell carcinoma, pleomorphic cell carcinoma, mucoepidermoid carcinoma, or the answer is adenoid cystic carcinoma. Thank you very much. Hope you will revise these MCQs questions. You will study different scenario. The scenario is for the postgraduate students, and the MCQ questions are for the undergraduate students, and the slide description is for the both to give the answer. Next, we will discuss the acinic cell carcinoma.